We were hoping that, by the end of tonight, you'll come away with a better understanding of what exactly a functional neurologic disorder is, and also maybe a little bit more about why it happens, understanding historical stigma around the idea of FND, and then maybe you'll come away with some more hope about how we can approach this problem and looking towards the future for better solutions. So if you remember the last talk we gave about the intersection of mental health and migraine, we proposed that there's a lot of these conditions that tend to travel along together. And so there are some patients who are suffering with multi-organ problems, many unexplained symptoms. And so it could be things like interstitial cystitis and IBS and endometriosis and migraine and fibro. All these things tend to travel along together more than you would expect in the general population. And at the root of it, often there's comorbid mental health disorders, which may arise because of the chronic pain situation, or sometimes they're antecedent, they come before. We talked a little bit about adverse childhood events as one of those potential risk factors. And so we won't go back into depth about that again. But for the purposes of today, we're going to be focusing on FND, or functional neurologic disorders. A quick circle back to our last talk as well about Cartesian dualism. And we're not going to go into depth here today, but just to remind you that Descartes, the same guy who gave us the graph paper to draw our functions on, unfortunately, he also left us with a very tricky legacy philosophically, that the mind and the body are separate. And, it may be important to try to dissect them when we're coming up with ideas to test as a hypothesis as we develop medical science. But we're seeing that really this model is actually more harmful, and oftentimes it leads us down erroneous conclusions, and we don't necessarily get the holistic kind of care that we need. So that will be a recurring theme throughout tonight, is the big divide between neurology and psychiatry. And functional disorders are this kind of unusual gray area that falls between the two specialties. So what exactly is a functional disorder? We'll go into more depth on that. Basically, it's an unexplained symptom that doesn't fit necessarily with established neurologic disorders. And so, for instance, I have some patients that say, I see 3 out of this eye and 5 out of this eye when I close each eye. And like, well, how could that possibly be? Or they can't walk forward, but they can walk backward. Strange things like this. And there are lots of variants. It can take many different forms. And the classic neurologist will rule out, organic diseases, which we'll define later, in their wheelhouse and say, well, there's nothing wrong with you neurologically. Go see a psychiatrist. And then the psychiatrist will see you and they'll say, oh, dizzy, vertigo, and weird multiple visions in your eye. Like, that's nothing to do with me. Like, you go see the neurologist. So for many of these patients, they're left wandering in the canyon between the two specialties. I wanted to show you this ancient painting, and it's actually a very famous painting in the history of medicine. It's called The Clinical Lesson at the Salpêtrière, and it shows the gentleman there standing to the left of the woman who's fainting is Dr. Charcot, who's one of the most famous neurologists. And this patient is also very famous. Her name is Marie Whitman. And this painting depicts a lot of famous neurologists in the audience as students. There's even Gilles de la Tourette, who described Tourette's syndrome, and many other contemporaries. But, so they were describing hysteria very early, and Charcot used a lot of different methods to try to test this. He helped to develop the rudimentary neurologic exam, but he also used a lot of other weird things like hypnosis and things. Ultimately, like, Marie Whitman was a very interesting patient, and it's still debated whether or not she truly had a functional syndrome, which they would have called hysteria at the time, or whether or not she had epilepsy, or perhaps, she might have been feigning symptoms, some people think. And the other theory is that perhaps there was some sort of mass psychosis thing going on at the hospital where she worked. And this is kind of interesting. She became, after Charcot's treatment, she did do much better. And she started to work at the hospital as a radiology tech. But because it was early days of radiation and they didn't know how to use proper protective equipment, she ended up suffering radiation poisoning and ended up having her arms amputated. So it's a very strange story, but she had a number of unusual symptoms, and it may have been related to some of her occupational hazards. So I think that's a really good reminder that, when we do delve into the territory of unexplained symptoms, you have to really dig deep and look at what people are actually doing day to day and the kind of exposures they have to make sure you're not missing a true organic illness. So I'll just show you just for record here. You can see these are all different famous neurologists superimposed. You can see their names. And so this painting is usually hung in the residence room as you're studying. So this takes us to the conception of hysteria, which really is an awful term that should have fallen out of use entirely, but it's still used in some quarters. And hysteria really refers to a wandering uterus, like you think of hysterectomy. And we get the word hysterical from it. And this dates back even to ancient Egypt and Mesopotamia, and subsequently the Greeks, who are kind of the forefathers of Western medicine, who had a theory that the uterus, this mischievous organ, would just wander around your body, wreaking havoc and causing problems. And this disease allegedly had a wide array of symptoms attributed to it, everything from anxiety, feeling short of breath, fainting, being nervous, either too much sexual desire or too little sexual desire, fluid retention, irritability, loss of appetite, or even just my favorite was the tendency to cause trouble for others. So basically you could just label someone who was difficult or you didn't like them with hysteria. And so, it ended up being used pejoratively often and used in ways sometimes to punish people. And really, it's not a valid word to use today when you think about trying to tie mental health symptoms to a uterus. So officially, hysteria was struck from the DSM in 1980, so before I was even born. But even during my training, the use of the term hysteria persists. And in Ontario, it's actually still part of our diagnostic codes, which we have been fighting to get stricken from that. So when we talk about functional disorders with our patients, one of the models that we often try to use to frame it in a simple analogy is the computer. And we think about organic versus inorganic as hardware versus software. And so, like I said, traditional neurology, we built our knowledge based on lesional studies. And lesions are things like tumors, strokes, bleeds, MS lesions. These are things that break a circuit. And we say, okay, well, when you break that circuit that was healthy, what happens? What's the symptom? So therefore, that circuit must do X. And so, over time, we developed lots of tools, whether it's through blood work, analysis of your spinal fluid, CT or MRI imaging, and the neurologic exam. Neurology is thought of like the worst, most sadistic Sudoku puzzle, that you're trying to use all your bits of information to localize exactly where the lesion is. And so a really good neurologist worth their salt can probably tell you where they think the lesion is or what the problem is before they even go to imaging, just based on their history and their exam. But there's limits to our magic. And so there are many symptoms for which a full examination, full imaging, full blood work and everything, there's no explanation. And so patients are left, feeling kind of frustrated that they don't have a good explanation for their symptoms. Now, when we talk about the software, on the other hand, I'm not saying that these symptoms are imaginary or feigned. They're very real for the patients that experience them. And they can actually be very disabling. It can prevent them from working and things. But there's no clear explanation based on our standard investigations. There are some modalities like functional magnetic resonance imaging, which we got into a little bit with the last talk. And so, again, going back to that analogy, it's more like not that you're missing something or it's damaged, but you have a whole orchestra, everyone's there, but just some people are playing out of tune. So, I think it's more like anything that the brain can do properly, it can do improperly. And so sometimes this can manifest. fMRI is not routinely available outside of research settings in Canada. So in our last talk, we talked about that interplay of stress, mood disorders, and chronic pain. And like I mentioned, classic neurology is really focused on treating the organic or lesional type disorders. So many neurologists will say, well, no, this isn't my wheelhouse. I'm focused on stroke or I'm focused on MS or epilepsy, and I don't treat these other types of disorders. And in a perfect world, probably the treatment would be sending to psychology and having a really good team led by the primary care provider with a neurologist to reassess periodically as needed. But the bulk of the care is going to be dealing with psychology and physiotherapy and things like that. So I tell my patients, look, while neurology can't always provide answers about why your symptoms are happening, at least I can rule out things that are immediately going to kill or disable you. And I think that's really important and can provide some real reassurance. And I always encourage my patients, even from the first visit, we're screening for mental health conditions. And I tell them it's really critical even if you don't have FND, just, chronic migraine can really wear on you and cause severe anxiety and depression, and you can start to withdraw socially. So it's really important that if you want to do a holistic sort of management and treatment, that we screen for these issues and you take it seriously and address it. So, maybe that's additional counseling or psychology or CBT. Or perhaps starting an antidepressant. So it's important to really not to minimize your mental health and to take it pretty seriously. So back to that chasm, we have Rene Descartes here, who happily created this nice gap for us between the two specialties. And then, Freud, who was a pupil of Charcot in that painting, he kind of broke off with the psychoanalytic model, and psychiatry spun out on its own and became its own specialty. And whether that was differences in the theories about why these symptoms happen and how the brain works, a little bit of academic rivalry, the two halves were sundered. And so actually, I think of our specialties as sister specialties. We really are picking away at the same problem from two different angles. So functional disease is in the middle. And I think the goal for the future is to try to take this rickety little bridge that we have between us, neuropsychiatry, and as we develop new tests, new ways of looking at the brain and imaging it and understanding how it's connected and working, my hope is that, you're going to see a nice little freeway built between us and we become one whole specialty again. So with that, we're going to delve into the inorganic, and I'm going to turn the table to Dr. Mack, who's going to help us understand the terms that we use, the conceptions within psychiatry of how we describe these disorders and how they've evolved over time. So, Mike, I'll turn it to you.
Thanks so much, Alex. And I echo your sentiments. We are sister disciplines in the field of medicine and science, and it is inevitable that one day, the two fields will combine, and happily so. So let's talk about the concepts of functional disorders as it pertains to the psychiatric diagnostic manual, the diagnostic and statistical manual for psychiatry. So that it's the psychiatric Bible from which we make diagnoses, we look at the criteria. That's what it tells us what conditions are described as such. So the term hysteria was effectively removed and basically struck away from the DSM with the publication of DSM-3 in 1980. So before that, hysteria was a formal psychiatric diagnosis. In 1980, it was removed, and this is really the start of the scientific side of psychiatry, spearheaded by Robert Spitzer at Columbia University. And prior to that, hysteria was a broad and very poorly defined category, often encompassing a wide range of somatic and dissociative symptoms. But by 1980, psychiatry had shifted towards more descriptive classifications. The term hysteria was abandoned in favor of more specific diagnoses such as somatization disorder, conversion disorder, which is the old name for functional neurological disorder, dissociative disorders, and borderline personality disorders in some historical contexts. And we continue to refine our diagnostic manual. We're overdue for the 6th edition. You can see that the last one was in 2013. Next slide, please. So when we deal with patients with medically unexplained symptoms, this is sort of thought process that we use to differentiate between the conditions. And today we're focusing on the functional neurological symptom disorder. And basically in these patients, the symptoms are produced unconsciously by the patient. Their motivation is usually unconscious. And there's no gain whatsoever. There's no primary or secondary gain. They're not, exhibiting these symptoms to get out of military service. They're not doing so to get disability credits. They're not doing so to be cared for as a patient. It's simply put, psychological stressors have manifested in the form of neurological signs and symptoms. And going down that pathway, these patients are under the umbrella diagnosis of somatic symptom and related disorders, of which functional neurological symptom disorder is one big part of it, and another part would be somatic symptom disorder. On the other hand, if the patient is producing the symptoms intentionally, then you have one of two diagnoses: factitious disorder, malingering. So in factitious disorder, the only gain is to be cared for as the patient, Whereas malingering, there's some secondary gain, of which I gave you some examples just now. Next slide, please. So with time, I've mentioned that the vernacular, the terms in which we describe these conditions have changed. Specific to conversion disorder, we've actually moved away from that and harmonized with our neurology colleagues, and we call it functional neurological symptom disorder. And there was that other diagnosis, somatization disorder, that has now been subsumed into the somatic symptom disorder category. Next slide, please. So brass tacks, these are the diagnostics criteria for functional neurological symptom disorder. You have to have one or more symptoms of altered voluntary motor or sensory function. And if you have clinical findings, they prove to be incompatible between the symptoms and signs being shown and recognized neurological or medical conditions. And there shouldn't be another medical or mental disorder that better explains the symptoms or deficits, which is that line is attached to every diagnosis in the DSM. And of course, the disorder is not a disorder unless it causes you some sort of distress, dysfunction, or a problem with your life. It doesn't cause you a problem with your life, it's not a disorder. Yep, next slide, please. Now, we can be very specific in terms of this diagnosis. So, not every person that carries the diagnosis of functional neurological symptom disorder is going to be the same person with the same findings. And as such, there are symptom type specifiers. And I've listed some of them there on the screen. Some people can present with paralysis or weakness. Some folks will demonstrate abnormal movements, such as a tremor or a problem walking. Some folks complain of difficulty swallowing. Some people have attacks like seizures. Some people can't speak. Some people have slurred speech or low volume in their speech. Some folks no longer able to smell properly. And of course, you can have mixed symptoms. You can have a combination of those symptom type specifiers. And on the right side of your screen, you're going to see episode and stressor specifiers. So these specifiers modify your prognosis. So an acute episode of functional neurological symptom disorder is such that the symptoms have been present for fewer than 6 months, and it's persistent if the symptoms have been occurring for 6 months or more. So if your symptoms are persistent, unfortunately, that just means that you have a more severe case of this. Your prognosis might be worse compared to somebody who's only had the symptoms for a shorter period of time. And then another set of specifiers, if there's been an identified psychological stressor, and of course you're gonna want to specify what that stressor is. Maybe it's moving away from town, getting a new job, having a breakup, etc., or without a psychological stressor. And in that situation, if a person's unable to identify a psychological stressor, then that is the more severe case. It means that the prognosis might be a bit worse. Next slide, please. So, based on that rule out criteria, another medical or mental disorder does not better explain the symptom or deficit. Now, at first glance, this sounds like functional neurological symptom disorder is a diagnosis of exclusion, but it's not, and here's why. So first off, positive diagnostic features are key. FND is diagnosed based on positive clinical signs and not just the absence of other explanations. And these signs can be specific to FND and include things like the famous Hoover sign, which people, they basically do a test to elucidate functional leg weakness, tremor entrainment for people with a functional tremor, or inconsistency or incongruence with known neurological disease patterns. And in other words, clinicians make a rule and diagnosis based on clinical evidence that points directly to FND. And number two, exclusion means ruling things out without knowing what it is. A diagnosis of exclusion means that a disorder is only diagnosed after everything else has been ruled out, often in the absence of positive findings. FND is different. It's actively diagnosed based on recognizable, reproducible features. And number three, the clause about not better explained ensures specificity. That phrase in the DSM-5 criteria ensures that the symptoms aren't more consistent with another condition, and that the diagnosis isn't made prematurely in someone with, for example, multiple sclerosis, epilepsy, or a psychiatric illness that better accounts for the presentation. It's not about excluding everything else, but about making sure that the most appropriate explanation is chosen based on the clinical evidence. And here is the second set of diagnoses when a person's symptoms are unconscious, the motivation is unconscious, and there's no primary or secondary gain. It's somatic symptom disorder, sort of a controversial diagnosis. The head of the DSM-4, Alan Francis, who was at Duke University, he doesn't like this diagnosis because he thinks that maybe up to 1 in 5 people in the general population might meet criteria for this. But it's defined as having one or more somatic symptom or symptoms that are distressing or result in significant disruption of daily life. You have to have excessive thoughts, feelings, or behaviors related to the somatic symptoms or associated health concerns as manifested by at least one of the following: disproportionate and persistent thoughts of the seriousness of one's symptoms, persistently high levels of anxiety about health or symptoms, and spending excessive time and energy to these symptoms or health concerns. And although any one symptom might not be continuously present, the state of being symptomatic is persistent, typically more than 6 months. And again, it comes with different specifiers. We have with predominant pain, if pain is the primary symptom. And then persistent would mean that there are severe symptoms, marked impairment of a long duration, usually more than 6 months. And then we can categorize things by severity. So mild would be only one of the symptoms in criterion B. Moderate would be 2 or more of the symptoms in criterion B. And severe would be 2 or more symptoms in criterion B plus multiple somatic complaints or one very severe symptom. And the key point here is that the diagnosis doesn't require the symptoms to be medically unexplained. Instead, it focuses on a psychological and behavioral response to the symptoms. If you spend a lot of time living your life worrying about the symptoms and changing your behavior, then you might meet criteria for this condition. So of note, functional neurological disorder does not equate to somatic symptom disorder. Both fall under the broader umbrella of somatic symptom-related disorders, but they're not mutually exclusive either. But let me just talk about some of the key differences in the DSM classification. In somatic symptom disorder, the issue here is about distress, preoccupation, excessive thoughts, and behaviors about the symptoms. The emphasis is on the psychological response. As for functional neurological symptom disorder, neurological symptoms are the ones that are focused on, and they're going to be inconsistent with known disorders, and there's an emphasis on positive clinical signs and functional disruption. So again, they're not mutually exclusive. And the common misconceptions when dealing with these conditions is that it's all in your head, which wrongly, you're taking these conditions and wrongly equating them with malingering or factitious disorder, or you're faking it, which is often misunderstood as, the person doing this on purpose. They're purposely doing this and they're seeking attention, which is not true. Next slide, please. So simply put, functional neurological disorder, is a condition where the brain has trouble sending and receiving signals properly, leading to neurologic symptoms that aren't caused by damage or disease. And the great news about this is that the symptoms are treatable, even if they don't show up on standard medical tests. And, as Dr. Melinyshyn has mentioned, we have essentially been describing and diagnosing and treating patients with this condition since time immemorial, and people do get better. So with that, I'm going to hand it over to Dr. Melinyshyn. Thank you.
Thank you very much, Dr. Mack. So you'll probably be left with your head spinning and wondering, how does this all relate to migraine, and why are we talking about this, through Migraine Canada? And it does. I think there has been a long, heated debate within neurology about whether migraine itself is an organic or inorganic disease. And in fact, I would say overwhelmingly now, people believe it to be organic as a biological disorder that is kind of a mix of everything from genetic and vascular, inflammatory, sensory processing that's disordered, neuromodulatory problems. So I would say no, migraine is not considered a functional neurologic disorder, but for the longest time, it was grouped within that family of somatoform disorders. I think migraine and FND overlap in a number of important ways. Both can involve sensory, motor, or visual symptoms, and sometimes auras, if you don't know what you're dealing with, or a brainstem aura, can look a lot like a bizarre functional disorder. Both can be triggered or worsened by stress, sleep disruption, or trauma. Some patients can have both, They often coexist. There are huge rates of functional disorders overlapping people with actual epilepsy, and they have psychogenic epilepsy, where you have the leads even on their brain or on the scalp, and you're watching them during an attack, and they're not actually having any difference in their brainwaves. And so it can coexist in the same person. Um, and so, I think migraine fought for so long to overcome its stigma that sometimes the neurologists who are dedicated to treating headache and they perpetuate the stigma of FND and mental health instead by just refusing to acknowledge that there's a connection and trying to keep migraine couched solely in the organic world. But like we talked about in the last session, there really is a clear interplay and connection between these disorders. Specifically for migraine, there's clearly a heritable component. We know there's a genetic issue, especially for people with aura. First degree relatives of migraineurs have 1.5 to 4 times the risk of developing migraine. And it's a polygenic thing, so there's multiple genes at play. And then there's a lot of things that kind of link it to other types of physiology, like we can objectively measure the cortical spreading depression, the changes in electrical activity and blood flow that go over the surface of your cortex of the brain, the outer part. And that correlates elegantly with aura symptoms and the positive and negative features of aura. We have been able to quantify specific inflammatory markers like substance P and CGRP and PACAP and new things that are becoming targets for new therapeutics that are much more efficacious. Turns out when you know what you're actually trying to block, it works a lot better. And as we understand more about the anatomy of the trigeminal system and the hypothalamus and how it's all linked up, we are able to come up with more rational explanations of all the features that come along with migraine. It's not just a headache. So on a number of fronts, there are many pieces of evidence that suggest migraine is in fact an organic illness. So migraine is a neuroinflammatory brain disease, but so is depression. A lot of these same pieces of evidence that we're starting to accumulate for migraine, we're also starting to be able to look at things like depression objectively and look at functional connectivity changes, and so we're the more we start to explain it, it becomes standard neurobiology in the canon of neurology, not just psychiatry. So, no good headache talk is going to be replete without a delve into the ICHD3 criteria. And so to look at the garden variety migraine, just to familiarize yourself, at least 5 attacks. They last 4 hours up to 3 days. Beyond that, you get the status migrainosus you end up in a merge with. They got to have 2 of the following. It's like a buffet. You don't need everything to fulfill it. One-sided, throbbing or pulsating, moderate to severe, where it's affecting your activities and function. And then people tend to avoid physical activity, or it's made worse by that, or they improve with rest. During the headache, they have to have one or the other or both of nausea, vomiting, light, or sound sensitivity. But for those of you in the audience who have migraine, there's many other symptoms that go along with this. There's all the aura symptoms that can happen, which are myriad. There are brain fog, neck pain, vertigo, all sorts of visual phenomena. And so we define these criteria very narrowly because when you're probing into the unknown, you need to have very strict definitions about how you study something scientifically. So we start with a very minute, limited scope of criteria. But as we learn more about the process, we're seeing that maybe that's a little too strict and we need to expand the criteria we use to define it. When we look at aura, there are, a number of different symptoms that come along. Visual symptoms like the classic tachopsia we showed on the other slide, the zigzag fortification spectrum that you might see. Sensory things like tingling, paresthesias, or numbness that migrate. They tend to start either in the face for the arm or the leg, and they can migrate slowly as it spreads over the surface of your brain. Speech problems, dysphagia is probably the most common one where people jumble words or they can't remember the word they're trying to say right before a migraine. Motor ones are in a category somewhat of their own. If you have half of your body go numb or something, you need to be worked up for hemiplegic migraine. And then there's brainstem features, which include things like slurring of the tongue, vertigo, tinnitus, the ringing in the ears, hypoacusis, which is like sounds feel just awful and, very loud and painful, double vision, diplopia, or like just general incoordination. And I have many patients who have all of these. And they've been examined thoroughly. They don't have any significant lesions on their scans, and their exam is relatively normal between attacks. And so in another age, they might have reasonably been labeled with a functional disorder, but actually we can prove that, in fact, they have aura. The main differentiation for me would be that it really has to happen in relation to their migraine attacks. And so we're seeing an increasing creep from emergency doctors and ENTs and other doctors saying, well, I don't know what it is. It must be migraine. And you're like, well, the person doesn't even have headaches. So, I'm really loath to apply a diagnosis of aura unless you truly have these symptoms only in relation to your headache attacks. Of course, you can have the so-called acephalgic migraine, the migraine aura without the headache, but that's actually very rare. And so before you evoke that, you really have to go look at other explanations. And in fact, sometimes it may be a functional disorder. So asking about aura and visual symptoms, some things you may commonly see, light sensitivity by far is the most common. Blurring of the vision or trouble focusing the eyes. It just feels like the eyes are out of focus, and people say they can even forcibly force them into focus. It's just harder. Scintillations are the sparkles or distorted little patches, the squiggles. Scotoma is a blurred patch or a little blind spot that you're like, I kind of have to turn my head just to see the whole thing of all your face because I'm missing this little blind spot. The tachopsia, which you can see here to the right, and then photopsia. So people just have blobs of color, self-lighting. When you close your eyes, you can see weird patches of color blossoming and changing. And if you weren't really trained in neurology or headache properly, and you heard people describing all these incredible, fabulous visual displays, you'd be like, oh yeah, sure. They must be making this up or something. And that's really not true. This is definitely a feature of migraine brain. So there are rare forms, things like the Alice in Wonderland syndrome, where people feel huge in a room or suddenly very small. And we think that that was the basis for which Lewis Carroll wrote some of his famous passages in Alice. And you can see other things like floaters that come in every dimension. I've heard every possible description of floaters, I think. And visual snow is a very rare one. It's not really part of the migraine canon, but it does seem to travel along with migraine. And people can see like static across their vision. It looks like it's snowing or TV static, or they have a weird vortex, especially when you're looking at blank surfaces. It's very frustrating for people. We talked about the language. We talked about the sensory march. We talked about the brainstem symptoms. Um, you know, some of these are indistinguishable from a stroke. So I've had many patients who came in repeatedly under stroke protocol when it turned out it was a hemiplegic migraine. So after your seventh visit for a stroke, you're like, well, I don't think we need to do the clot buster because it's very clear that this is migraine and we have to get that under better control. So auras are in about 10% of patients with migraine, and typically they last 10 to 60 minutes and they resolve just prior to a headache onset, but it's variable. Like for some people, it may persist into the first part of the migraine, or it may persist, especially with the hemiplegic migraine. It can go on for days or even a month sometimes, but you have to be careful. So the first pearl here is that migraines describe floaters of every variety. Like if you have a migraine clinic, you've had patients describe every possible weird thing they could see. It's really important that if you're experiencing this, you go to your optometrist. You need a full eye exam. Your neurologist can't do all the exams that an eye doctor can do. We can like check in the back for pressure or something. But in reality, if you want to make sure you're preserving your vision, you got to go to the eye doctor. And this is really critical because once you start to lose vision from another cause, it's really hard to get it back. It's bad. It's something you really want to prevent from happening. So I have a very low threshold for directing my patients to the optometrist for a full ocular assessment. You got to rule out things like glaucoma or macular degeneration or tears or whatever. And that's something that only the eye doctor can do for you. So associated symptoms. These are the classic vignettes of migraine that they teach all the medical students, okay, or if you're going through neurology. Um, and so migraine, throbbing, moderate to severe, we just talked about that. Tension doesn't have any of those features or the features of the cluster headache family. There's IIH, which is a headache that if you heard the story and you didn't see the person, it sounds almost indistinguishable from migraine. But they have swelling in the back of their eyes in the disc because the pressure from so much pressure in their head is pushing out the eyes, and it's causing visual symptoms, double vision, transient loss of vision, weird things like that. And you can see some of the features on the imaging. SIH, which is a spinal leak, or perhaps just a lack of compliance. There's not enough liquid buoying up the brain, and that can be an unusual type of headache. And lastly, the cervicogenic, which I think is really overdiagnosed by physiotherapists and chiropractors because they're kind of focused on the neck. But in reality, there probably aren't as many of those floating around as people think. But the joke that we like to tell ourselves in clinic is that patients don't read the textbook, and that these vignettes are idealized forms of those diseases that are meant to serve as caricatures that help us make a good diagnosis. So you don't have to fit neatly into those boxes, and many patients do not. So for instance, like I have many migraineurs who do not have a throbbing character. The headache isn't symmetrical. It's actually pretty both sides the same. And instead of being frontotemporal, it's occipital predominant. There's other phenotypes, the way the headache presents. And in addition to the core features, people have neck pain, vertigo, disequilibrium, feeling unbalanced all the time, brain fog, the visual phenomena that persist even between attacks. And they may have autonomic features like a cluster headache, but just not enough of them to make the diagnosis. So as you start to see more and more people, you realize, well, they don't fit neatly into those definitions. And that goes for other things as well. Cluster headaches, which are supposed to be side locked, I have a patient where it flips from side to side over years. So when they have a different cycle of cluster, it happened on the other side this year for some reason. For IIH, we always like to look in it for people who are very overweight or obese, but I have skinny patients with IIH who maybe have, some other kind of issue going on, or perhaps they don't have the blurring in the back of their eyes, but you pick it up on a very subtle type of OCT, a type of imaging of the eyes to look for swelling. It's always important that you explore these different things and really take a thorough headache history. And this is going to help you differentiate those features. So that's the reality. Radiation. So the headache doesn't actually just have to be in your scalp. Okay. Often the trigeminal nerve, which is the main pathway for migraine pain, it starts in the hypothalamus, but it's carried out through nerve number 5, trigeminal. It innervates a lot of stuff in your head. So it innervates the cornea. You can have ocular pain. And it also has 3 divisions. This is why it's called trigeminal, 3 twins. And so, most commonly it's the first division, frontotemporal, but you can have pain in V2 and V3, and this can present as sinus discomfort or dental pain. So, there was a big review that said, probably 80% or more of patients with a sinus headache diagnosed by themselves or their family doctor actually have migraine. And these patients will often go to ENT to have a hole drilled into their sinus or correct their septum that's deviated. It doesn't do anything. I've had patients with an atypical lower face migraine in their teeth, and they've had all their teeth on one side pulled by a dentist with partial plates, and they still are in pain. And you're like, well, it actually might be your migraine. And really to do that, you can test it a couple ways. Like, does it respond to a triptan when they have an attack? Like that, triptans are pretty migraine specific, so that's an easy, safe way to check it. But again, I want to emphasize that just because you don't have an explanation for symptoms doesn't mean it's migraine, but it's important to consider it as one possibility. Other things, it can radiate into the jaw, it can radiate into the ear. People often have neck and shoulder stiffness because all of these things are innervated by that trigeminal cervical complex. And lastly, the cervical roots C1, C2, C3, they actually come back up from the neck and form occipital nerves, which do the back of your head. And so often migraineurs will have at the bottom of the trigeminal cervical complex, if that's activated, they get occipital pain. So all of these can be part of the migraine. It's not just a frontotemporal headache. This graph, you've probably seen it before, but I love to show it because I like to emphasize that migraine is not just a headache. You can have the aura before, like we already talked about, but there's a prodrome with troubles of concentration, irritability, or elated mood, difficulty speaking and reading, yawning. I got someone that yawns 3 or 4 times in a row and they know it's coming. That's when they treat with a triptan. And you can have the sensitivity to light and sound before the headache or after. And if you're having repeated attacks, you never actually go back to baseline. So you're always stuck in this interictal postdrome, prodrome kind of period. And so I think this just explanation gives some patients a lot of reassurance because they have a good physical, they have good imaging, and they've just been looking for an explanation as to why they have these symptoms. And the answer is it's migraine, and it's a neuroinflammatory condition. So just for your reference, I wanted to give you the criteria for migraine with brainstem aura. And of note, they exclude the motor or retinal symptoms because these are classified as separate types of migraine, the hemiplegic migraine or a retinal migraine. And retinal migraine, in contrast to the typical visual aura, you got to check each eye. So, if it truly is only one eye, then it's retinal, and you need to go see an eye doctor and maybe consider some vascular imaging of your neck. But most people, even if they believe it's one eye, it's actually not. It's usually a typical aura. So for hemiplegic, This is focusing more on the motor weakness, and the symptoms are fully reversible. So that's an important feature. But, if you just looked at this, I mean, cover up the hemiplegic migraine, I mean, it kind of sounds like it could also be a TIA, which is the mini stroke, because it resolves completely. So I would say the main difference between those two is that there's a gradual evolution typically with aura. So as that cortical spreading depression is traveling over the surface of your brain, you're going to have maybe a sensory march or even the motor march, the Jacksonian march. It's like it kind of spreads over time. And yeah, sure, some strokes perhaps can mimic that. It's less common. And the mini stroke is like really like a bam. It's like a rapid onset thing because you're blocking a blood vessel. So I would say that and the characteristic features that are so unique to aura, like the zigzag tachopsia. If you got that, I mean, that's a hole in one. You've got migraine in front of you. So then, realistically, how do we deal with these symptoms? If any of my patients are in the audience, I spend 90 minutes on my first consult. I book everybody for 90 minutes, and we go through a long laundry list of symptoms. And I think every neurologist sometimes feels exasperated because we have patients that literally say yes to every possible symptom. And I'll take my story first. I like to let my patients speak, and I hear their story, and then I want to go back and I have a bridge in my note, and I say, well, here's what the patient spontaneously told me. And then I started asking specifically about symptoms. And it's incredible. Like, sometimes patients don't tell you that they're blind in one eye and their left leg doesn't work and they have vertigo and numbness. And you're like, how is it possible you have all these symptoms and you didn't mention any of that in the first 30 minutes of the appointment? And it can be frustrating, but there are also people who it's like a compulsion. They say yes to everything. And they're like, well, actually, no, I don't really have that. But, I think about it and, that sounds interesting. You're like, what do you, no, I'm like, I need to know what your symptoms actually are. And, so I had a famous mentor in neurology who said, well, when you get people like this, you have to ask them, like, does it tingle in your upper teeth when you push too hard to urinate or something? And if they say yes to that, then they're not telling the truth because there's no way that could happen. But is there more of a link? So, we talked about this idea that they're all linked together. And when someone presents like this to the neurologist, it doesn't come as a nice crystalline formulation that I can say, you've got this and you've got this. People come to you with all their complexity. They come wrapped up like a giant knot, and it's very difficult to figure it out. Many patients can't tell you reliably when their symptoms started. It was more than 20 years ago, and they don't remember what they were doing at the time or how it really changed over time. So it really is a very difficult thing for your doctor and you to set off on this journey to try to pick apart at the edges. And you have to start somewhere. You have to find one little edge that you can start picking at the knot. So how common are these issues in the clinic? So again, because we've had so many definitions of how we define these disorders, the older papers use older terms, right? So if you look at the somatoform disorders, Dr. Mack already kind of went over that with you. As over a fifth of patients presenting to primary care are thought to have some form of somatic disorder, which also includes things like headache and pain syndromes. In the neurology clinic, it was even higher. It gets concentrated, more than a third of patients. So in one really key study that was done, 30% of neuroreferrals had symptoms that could not be explained by organic disease. So it's very, very common. They tried to break it down by what was actually going on, and the true functional was probably about a quarter. Headache disorders were a quarter. Conversion symptoms, by the old definitions, like things like motor or sensory symptoms you couldn't explain, or psychogenic non-epileptic seizures, about 20%. But what was reassuring, and I think this is a useful piece of information to tell your patients with FND that are worried, when you follow these patients for a year and a half, only 0.4% ended up with an organic disease that was unexpected at the initial assessment. So if your doctor suspects you have FND or a somatoform disorder, it's pretty much guaranteed. Like, we don't just like slap this on because we're being lazy or we don't want to explore your symptoms more. Like, there truly are features that tip us off to this being the reality. And so I would say you can be very reasonably assured that this is the cause of your problems if your doctor is having this serious conversation with you. When we use the more modern terms like FND, this is now in a 2010 study, second most common diagnosis in neurology clinics behind headache. And I would argue that headache and FND are probably the areas neurologists have the least interest in treating, so that tells you something. And it's somewhere between, depending on the estimate, in another study in 2018, between 5 and 16% of new neurology outpatient referrals. So this is a real problem. It causes severe disability. These people often will see 4 or 5 neurologists because maybe the neurologist didn't have the proper conversation with them about what FND truly means. Or maybe the patient's in denial. I have a lot of patients who refuse to accept the diagnosis because they have internalized the stigma about mental health conditions. And so they're not ready to really do the work of working with a psychologist and a physiotherapist to address this. Why does FND happen? Now, this slide is really dense, but I wanted to show you that there are many theories about why this happens. I will say, probably the leaders for me are probably biopsychosocial and functional connectivity theories, but there have been many different theories about why this happens depending on your field of study, whether you're a psychologist or a psychiatrist or a neurobiologist. We're all kind of looking at it in a different way. Some of the theories focus on acute stress reactions or chronic stress and trauma, and people are manifesting neurologic symptoms in response to this because they're not dealing with it in a healthier way. Others are looking at biological and chemical alterations or changes in connectivity. And it's not that one theory is better than another. These are clearly just all people kind of examining the same problem from different perspectives. And so I think there's something that you can learn from reading the teachings of all of these lines of inquiry. And probably the truth lies somewhere in the middle of all of them. All of these things are little tidbits that are helping us to understand it from a different perspective. Now, if you've heard my other talks, I like to wax on fMRI studies, probably more than others. But this one is just a reference slide that I keep for myself and I do it for different conditions. And I try to look for functional connectivity, what areas are key areas that are implicated. And this is a lot of stuff that was also implicated in migraine and trauma that we talked about in the last one. So anterior cingulate, the insula, which controls your fight and flight and your rest and digest, motor cortex, basal ganglia, which regulates movement. And so maybe this is why these people have these abnormal movement disorders like tremors or inability to move something. It's a trouble initiating the motor program or it's disordered in some way. And so it's really fascinating. And I think we have to move away from blaming patients because we don't have the tools to explain what's wrong with them or saying they're just very mentally ill, to kind of investing more money and time into researching why this happens. And I think that's the way to the future. I already said it before, but I'll say it again. Functional disorders commonly co-occur with organic disease. Look, no one likes to hear it's all in your head, but just hear me out here. The truth is that everything that you feel and you perceive, everything you see, everything you touch, it's not actually happening in your eyeball. It's not actually happening at the end of your fingertips. Your nerves are sending signals back to your brain, and based on your previous experiences and memories and everything, it's integrating this into a virtual reality of everything around you. And so what I would argue is that anything your brain can do correctly, it can do incorrectly. And so this is where you end up with disorders of perception, sensation, and movement. So what is the boundary between neurology and psychiatry? When is a disease mental and when is it organic? And as we become better at describing these mechanisms underlying it, like, does it even matter? They seem very tangled together and it's the same lump of tofu. It's really kind of silly to try to divide these two systems, except when we're using a reductionist model to study things very specifically. So I would argue, from my personal opinion, that mental health disorders are just another type of brain disease. It's all kind of grounded in biochemistry. This paper here, it describes this controversy. And, I think a lot of academics are still duking it out about the true nature of functional disorders, whether they are more mental or whether they're more organic, or even if that matters. This article, I would say, gives a really great background to any clinicians or patients who are interested in learning more about the ideas of kind of challenging the old paradigms of how we think about these problems. And they wrote that, when a change in nomenclature and the shift to agnosticism, which means like we don't really know why it happens, we're moving away from using psychodynamic models. When they planned that, the declared motivation for this was that it would destigmatize these conditions. And rightfully so, the author kind of calls us out and says, we can't really destigmatize a condition by changing the name or redefining it or just massaging the conceptualization. that it becomes something that it isn't. And I agree, this is a sleight of hand. It's a pseudo destigmatization, and you're trying to sanitize a condition by rescuing it from a label of it being psychiatric. Um, and if you think about that, you're like, yeah, well, we want legitimacy, we want to be treated with respect and everything, and I agree. But if you're changing it to save it from a psychiatric label, what does that say about our stance about how we treat all mental health concerns? Like they should not be stigmatized this way. They should not have a stain on the individual for dealing with these problems. And to kind of contrast this, I would show you the historical names that we used for mental health facilities. It started with things like a madhouse or Bedlam, which was named after Bethlehem Hospital, which is like a notorious awful place in London where they kept people with mental health conditions. Then they renamed it to lunatic asylum, thinking that the madness was linked to lunar cycles. And then that became kind of bizarre and antiquated. So they're like, well, we're going to call it an insane asylum. And insane used to mean unhealthy. Like sana is health, so you're insane. So it's just a place for people for shelter who are unhealthy. Then it became a mental hospital. Then it became a state hospital or provincial hospital, which sounds more neutral. It talks about like public ownership of taking care of these people. But then that became stigmatized. So we called it a sanatorium, going back to the healthiness, which is thought, to be a little bit more non-specific. We had people with TB and other neuroses kept there. Then it became psychiatric hospital, which sounded more formal and medical. And then we called it a mental institution. And then we named it a behavioral health facility. And then we call it mental health center. Now we kind of move to things like Dr. Mack works at CAMH. We have all these other acronyms and we try to sidestep the stigma using that. But the reality is that, like, a rose by any other name. Um, the reason it's stigmatized is not because these issues are inherently psychiatric, but because they're difficult to treat. Physicians often aren't equipped with the tools or resources to manage them. And it results in real problems for both patients, the people who live with them, and their providers. So I think, we have to get to the heart of the issue, which is actually developing good tools and resources to help people manage these problems, instead of just playing, political games and renaming things. So to actually destigmatize the condition, we have to accept it for what it is, face it squarely, strongly advocate for acceptance and treatment and support. So, these conditions are as real as any other medical condition. They're produced by non-conscious and involuntary mechanisms, and they can strike anyone in our society. They're very, very common. They happen across socioeconomic boundaries. And they do not necessarily represent malingering, although the other open secret is like, yes, there are many malingerers who come through. And they can be highly distressing and disabling. So I think people with FND, they deserve respect, they deserve resources, and we need to continue to advocate for them. So you've been diagnosed with FND. What can you do about it? I listed some of the things that you can do. Education is the cornerstone of this. So, with early detection of FND and you explain how it works, people have excellent prognoses, and even sometimes even just having a good conversation about it and igniting that drive to reflect inward actually can be curative. So, compassionate, clear explanations of why you're content that they are not in danger. Your exam is normal, your scans are good. That's very helpful. Physiotherapy is really important, and you can tailor it to the specific symptom with the FND, whether that's movement disorders or dystonia or something weird. Cognitive behavioral therapy, I think, is probably the cornerstone. You just hear CBT is useful for so many different things. I don't think there's any person, even if you're healthy, that would not benefit from cognitive behavioral therapy, but it can help you to get out of that rumination and the focusing on the symptoms, which can really have incredible results. Occupational therapy can help with pacing strategies and getting you back to work in your environment. Psychology, speech language for if you're having more swallowing or functional voice or speech problems. Medication, not specifically for FND, but for your comorbid issues like chronic pain conditions, anxiety, depression, PTSD, you want to, like I said, pick at that knot from different angles, and you want to think about the holistic problem. And lastly, multidisciplinary team care. Really, like a single neurologist working in the community is not the place you want to be with FND. That's not going to help you. The neurologist is there really to confirm the diagnosis, but they're not really trained in long-term management. They can't help you just by visiting. And so really you need to have a whole array of therapists, psychologists, and I would say the primary care person still remains the big quarterback in all these care models. So what's your prognosis? 60 to 70% of people with FND improve with the appropriate treatment, even just with education. I think 74%, so almost three quarters, in a structured multidisciplinary program improve their motor function when they have things like weakness or tremors at 1 year. And, maybe in Canada, we don't have these big developed programs yet, but you do start to see them at the larger academic institutions in the States. And so I'm hopeful that trend will continue to spread north of the border. And 60% of patients with functional weakness report improvement, but that sometimes they still have waxing, waning symptoms, or it may be mild and it just kind of stutters. Especially when symptoms had lasted over a year, they tend to have a little bit of a more guarded prognosis. I just wanted to show this as something aspirational. This is from the Neurology Academy website, but it shows perhaps what would be an ideal care pathway for patients with FND. And you can see it's not hierarchical, it's not a pyramid. It's a team of people that have kind of contingencies and plans to help manage these symptoms. But realistically, a general neurology practice is not the best place to manage this. You need a whole array, an interdisciplinary team, OT, PT, psychiatry, psychology, social work. But this is definitely something aspirational that hopefully we can work to develop here in Ontario and the rest of Canada. So migraine and FND, they're not just a specialty problem. People with FND present to providers at all different stages of their healthcare journey, and it really does take a village to help them. And I would say we need to be transparent and honest. Patients, they need to explore the diagnosis and optimize their mental health. You have to own it. And that's the only way out of this sometimes, is to really, work with your providers to really address it and make sure you're doing everything you can when able, that you're able to secure some mental health help. And clinicians of all types need to learn about this because it really does present in every single different discipline. Whether it's fibro or interstitial cystitis or chronic pelvic pain that's unexplained or all these different pain syndromes that people are wandering looking for solutions, this might be part of the answer. And public payers need to recognize that even if you're heartless and you don't care about human suffering, economically, the impact of this is huge. It affects people of working age, of all ages, of all different SES, social economic strata. It really is something where people will go from provider to provider. I've had one patient that saw 7 neurologists. And that just isn't a good use of our resources when there's so many people waiting to see a neurologist. It's not going to change what we're doing. So we need to give these people a good pathway that actually gets them feeling better instead of just going through the revolving turnstile. This is an excellent website. So I send a lot of my patients with FND to this website, and it explains everything in terms of videos. There's written materials. There's something to explain all the different types of FND. So definitely check it out if you're interested. They have fact sheets on everything from cognitive symptoms like brain fog, dissociative things, seizures, functional dystonias, tremors, everything. So, it's a really fascinating read. And I would definitely go to this website if you need to find more information. They have a great one on chronic daily headache as well. So just a shout out there. Another one that I absolutely love is Dr. Sullivan. She does a lot of different popular topics, I think, but there's some really great ones about FND, brain fog, white matter disease, which is not just MS and vasculitis, but you can have non-specific white matter lesions and things that are just very common to migraine. And they're not really anything to worry about, but I think her videos do a really good service, helping people to learn more about these issues. A shout out to the Functional Neurologic Disorder Society. Excellent group of people, a lot of up and coming thinkers and academics. And this year it's going to be in Baltimore, Maryland. But it's a wonderful meeting of people who are very fascinated by FND and learning about its manifestations and trying to come to a better solution. So, final thoughts. FND is a condition where the brain has difficulty sending and receiving signals properly, can manifest as almost anything that can be done correctly, can be done incorrectly, does not have any structural damage or disease. The investigations are all negative, doesn't appear on standard tests. FND is one of the most common reasons for referral to neurology clinics, often coexists with actual organic disease, if you want to think about it that way. And addressing your mental health comorbidities, whether it's anxiety, depression, trauma, very important in the context of FND, thinking of it as a holistic problem. And we just have to focus on clear, compassionate education, diagnosis and interdisciplinary care that's tailored to the needs of the person with FND. And with this treatment, I think the outlook is very positive. It's a message of hope, actually, because it's better that you have this than something like MS or a stroke or something. There's a really good chance that you can make a wonderful functional recovery and still be very happy and healthy. And with that, I'd like to thank you for your attention.